معنا دلوقتي استاذ الدكتور عزة عبد الحميد بروفيسور اوف راديولوجي فاكولتي اوف ميديسن سويس كانال يونيفرستي، وهتكلمنا دلوقتي عن الالترا ساوند رول في الدايجنوزس اوف بيدياتريك ايمرجنسي. بعد التوك دي في اناونسمنت وهيبقى في بريك ان شاء الله.
طيب شكرا. ثانك يو مستر تشيرمان. بسم الله الرحمن الرحيم. بداية طبعا أنا لازم أشكر الزميل الفاضل يعني والأخ العزيز دكتور أسامة عرفة. في صدى صوت جامد قوي. أنا كويس صوت سامعني؟ الصوت واطي؟ طيب أنا صوتي واطي على دلوقتي. وعارفة إنكم زهقتوا وعايزين كوفي بريك، أنا كمان عايزة كوفي بريك، لكن أوعدكم المحاضرة ديت مش طويلة وإن شاء الله هناخد أقل من allocated time. Okay, starting with the ultrasound of pediatric emergencies. Advantages of ultrasound are many: low cost, non-invasive, easily accessible, painless, quickly performed, can be repeated with absence of ionizing radiation. The main disadvantage of ultrasound is operator dependence. In this lecture, I'm going to talk about uses of emergency ultrasound in abdominal trauma, bowel pathology, pancreatic, biliary, renal emergencies, scrotal, female pelvis, cranial, as well as musculoskeletal pathology. Starting with the traumatic pathology, the technique of ultrasound is special. Okay, we don't do a routine whole abdominal ultrasound in trauma, but we used focused assessment with sonography for trauma. It's called FAST. It's a rapidly performed bedside study to identify ectopic abdominal fluid. A positive FAST is defined as presence of fluid seen as anechoic volume independent regions of the peritoneal cavity. So detection of free fluid by ultrasound is done in 3 locations: the right upper quadrant, left upper quadrant, and the pelvis. This is our first case, a 3-year-old status post motor vehicle accident. Fast ultrasound demonstrates, for those who are not familiar with the images of ultrasound, anechoic means black signal. So this is the urinary bladder containing urine which appears black. You see black signal outside the confines of the urinary bladder indicating free fluid within the pelvis. This is the left hypochondrium. This dotted line here represents the spleen. That's the kidney. You can see also anechoic area here surrounding the spleen. So this is positive for fluid. We did CT for the same patient. As you see here, there is laceration of the spleen, which was the cause of this internal hemorrhage. Let's move to GI emergencies in pediatrics. Ultrasound can diagnose malrotation, pyloric stenosis, intussusception, and appendicitis. Our second case is an 8-month-old presented to the ED with bilious vomiting. This is the ultrasound at the region of the epigastrium. That structure here is the superior mesenteric artery. And that crescentic one here is the vein, superior mesenteric vein. Normally, the vein should be located at the right side of the artery. So this mirror image here indicates malrotation. So malrotation can be diagnosed with ultrasound. Our third case is a 4-week-old boy with non-bilious vomiting. This is ultrasound at the epigastrium. This one here is the gallbladder, and that's the pyloric antrum. Longitudinal scan here revealed lengthening of the pyloric canal. It measures 21.5 millimeter, more than 15. And these cursors here indicates or measures the muscular layer, which was 5 millimeter, more than 4. So this is a case of CHIPS. Let's go to case number 4, a 1-year-old with abdominal stension and bloody stools. At the right iliac fossa, you can see this target sign, a bowel mass. It has a very characteristic appearance in the TS and LS. You can see alternating layers of the bowel loops. Hyperechoic, this white line here, and then anechoic, hyperechoic, anechoic, and so on. This is typical for intussusception. We did color Doppler for the same patient, and you can see here normal vascularity, which excludes ischemia. Also, distal to the intussusception, you can figure out these round masses, lymphoma. So also you can diagnose the lead point for intussusception. Not only the intussusception, but if there is secondary intussusception as well. Another case of intussusception, and the lead point here was proved to be a duplication cyst. Another case, also showing early sign of ischemia of intussusception. You can see this fluid signal, okay, here in the middle of the intussusception. This is an early sign of ischemia. Going to the sixth case, a 5-year-old child presenting with right lower quadrant pain. At the right iliac fossa, you can see this tubular fluid field structure with a blind end, with hypervascularity. The thickness was more than 1 centimeter, so this is a case of acute appendicitis. Let's go to scrotal emergencies. I will cover the testicular torsion and epididymitis. Of course, other causes for scrotal emergencies are there and can also be diagnosed with ultrasound. But I will take only 2 examples. Our 7th case here is a 9-year-old boy presented with right testicular pain for the past 12 hours. Ultrasound of the testes here demonstrate an altered echogenicity. Compare the right to the left. This is the normal echogenicity. This appears a little bit hypoechoic. Doing color Doppler study at the left testis, you can see normal vascularity with absent vascularity at the right. This was a case of testicular torsion, ischemia, and orchectomy was done on the right side. This case here, a 14-year-old boy presented with right scrotal pain, hypervascularity of the epididymis. Compare the right to the left side. You can see normal vascularity. Here is hypervascularity, and this fluid signal here surrounding the epididymis, a case of acute epididymitis. Let's go to the female pelvic emergencies. I will talk about the congenital anomalies, ovarian masses, and ovarian torsion. An 11-year-old girl presented with pelvic pain and primary amenorrhea. That dashed arrow here points to the uterus. It appears fine. And the vagina here appears distended with this blood. Okay, so it was a case of imperforate hymen. The other case here is 13-year-old girl with right-sided pelvic pain. That's the right ovary appears enlarged, echogenic stroma. Follicles are displaced subcapsularly in a peripheral location, and you can see this clear cyst here measuring that by that. Color Doppler reveals no vascularity, so it was a case of ovarian cyst causing torsion of the ovary, and of course, oophorectomy was done. The pancreatic biliary conditions, I will talk about the choledochal cysts. This is a 2-year-old presented with severe colicky abdominal pain lasting a few minutes, then resolving without treatment. This slide here shows the common bile duct. It appears tortuous with fusiform dilatation. MRCP proved the same findings. So this was a case, choledochal cyst type 1. Another case here, you can see the gallbladder, okay, normal. This is the region of the common bile duct, a cyst there, and that's the portal vein. Another cyst was seen at the left lobe of the liver. MRCP showed the same findings, so this was a case of choledochal cyst type 4A. Let's go to the renal conditions: pyelonephritis, uretropelvic junction obstruction, and renal stones. A 15-year-old child with right loin pain Okay, here dilatation of the pelvic calyceal system with an impacted stone at the upper ureter. In acute pyelonephritis, we can diagnose diffuse form and multifocal pyelonephritis. In the diffuse form, compare the diseased side with the normal side, enlarged kidney with loss of corticomedullary differentiation. In the multifocal type, you can see these hypoechoic areas within the renal cortex without vascularity. So diffuse and multifocal pyelonephritis. Let's go to the cranial conditions. Cranial ultrasound is used in young infants with an open anterior fontanelle to diagnose parenchymal abnormality like hemorrhage, hydrocephalus, tumor, etc., to differentiate benign enlargement of subarachnoid spaces from subdural collections. And this is our first case here. An infant presenting with enlarging head circumference. As I told you, fluid appears with that black signal. So these are the lateral ventricles. You can see another fluid here, extraaxial to the brain. Now we should answer a question. Is that subdural or subarachnoid? Because management is completely different. So we opened this color box and we found the blood vessels going towards the brain. So this is subdural. In subarachnoid, the vessels traverse the collection. Actually, sometimes I cannot make the differentiation with MRI, and ultrasound is much better. But provided that the child have still patent anterior fontanelle. This is a preterm newborn. Okay. Coronary ultrasound, that's the normal right lateral ventricle, and this is the choroid plexus. You can see clear CSF. Compare it to the diseased one. It is distended with blood. In the sagittal view, also blood here, filling the ventricle with hyper-echoic areas at the periventricular locations. It was a case of intracranial hemorrhage, and we can do the grading of that hemorrhage by ultrasound criteria. Another case of preterm newborn, you can see here dilated lateral ventricle and these cystic areas at periventricular location in sagittal and coronal planes. This is a case of periventricular leukomalacia. Again, we can grade this. The last condition here, evaluation of joint effusion, particularly the hip, guidance for drainage and localization of non-radiopaque foreign bodies. Our last case, a male child presenting at what year, refusing to walk on the left lower extremity following a history of a viral infection a few days before. This is the normal right hip. That's the head, the greater tubercle or the greater trochanter, and this is the neck. Compare it to fluid here seen in the dependent part anterior to the neck. It was a case of knee effusion, hip effusion, with due to septic arthritis. In conclusion, ultrasonography has many applications in the evaluation of pediatric patients presenting to the ED with both traumatic and non-traumatic emergencies. It also has become the modality of choice in imaging of both a stable and unstable pediatric patient in the ED. Thank you. أنا بس أحب أعرفكم على حفيدتي دي لارا. Say hi, Lara. Very much.
شركة مونو ميديا ترجو لكم دوام المناسبات السعيدة.